I'm Juliette Mundy. I'm Director of Public Health for Watch Health Aboriginal Corporation. I'd like to start by acknowledging the Ngunnawal people and paying my respects to elders past, present and emerging leaders. I would also like to acknowledge the Yolngu and Ndiliakwa and Ngunnawal people of the region that I work, which is on the screen. So Watch is the Aboriginal Community Mental Health Service for North East Arnhem Land, which is a very large area with a small dispersed population. So I think it says up there the population, the total population of the region is about 10,000, 93.6% of whom identify as Aboriginal and or Torres Strait Islander, and correspondingly around about 90% of people speak a language other than English at home. So Watch operates 7 primary healthcare clinics in the region and 1 wellbeing centre, which are all along the top of the map there. And we also have a renal program at Great Island, which is a smaller island there. So we have 10 rural community workers on the TIS program, and they work in their own communities, so they're at all of the locations that are marked in red. I just wanted to share the strategic goals for the organisation. I don't know if you can read that, because they underpin how we deliver all of our services. The organisation was set up with the aim of becoming the primary healthcare provider for the whole of North East Arnhem, and we've gone through a period of rapid growth. We transitioned 2 clinics most recently in July 2019, so we're kind of in a period of consolidation and system strengthening at the moment. The 2 strategic goals that I think are really important for the TIS program are around respecting and engaging with Aboriginal forms of authority and decision making. So everything that we're doing is trying to empower our communities, and that's not just through health, it's through all areas that we feel we can have an advocacy role. And the last one, which is supporting the empowerment of the local Aboriginal workforce with meaningful career pathways and progression. So the bad news here. This is smoking stats for our region compared to the general Aboriginal and Torres Strait Islander population and the Australian population. So the data from our Communicare shows about 62% of our population aged 15 and over that have recorded smoking status are identifying as smokers. We also know that children under the age of 15 are smoking, and in opportunistic surveying, around half of that age group identify as smoking, between 10 to 14, which is pretty high. And this is broken down by community, and we can see over the last 5 years there hasn't been much change in those rates. There are obviously some differences there between communities, but they actually correspond with the proportion of the population that actually have a smoking status recorded. So the more people we've got a recorded status for, the higher the rates of smoking. So it just kind of shows that the people that we aren't asking are probably smokers. And there have been some small year-to-year fluctuations in quit status, but there's nothing that we can identify as a trend to say that people are quitting. This is the national KPI on smoking and pregnancy. So Watch currently has 2 Communicare databases because we haven't yet done a merger with the recent clinics. So I'm not sure if you can read it, but in our main database, we've got 65.9% of pregnant women with a recorded status as smoker, and then in the 2 new clinics that have transitioned, it's 50%. So that is a big difference, but it may also be in how that question's being asked, because Watch, the top database is the community controlled health services, and the bottom one is the clinics that have transitioned from government. So we need to kind of understand that a bit better, if there is a difference between the 2, or if it's just how people are reporting that information. And this shows smokers, non-smokers, and women who are quitting during pregnancy. this data is kind of problematic because the status could be any time within the last 12 months. So it depends on when they were asked, and we haven't really kind of teased that out. I think we need to do more to understand, at the time of pregnancy, whether women are smoking and if they're quitting during pregnancy or if it's kind of in that 12 months before. But it does suggest that the rates are lower in pregnant women than they are in the general population in our region. So I just wanted to share this because there's two really great resources that have been produced. So about the history of Nali, which is tobacco in our region. So I'm not sure, people might be aware, but it was first brought to East Arnhem by the Macassans over 300 years ago. And it's been adopted into Yolngu culture. And that has become quite complex in terms of how people understand tobacco as part of their culture. And it differs depending on who you talk to. So the short ones is some stories from the region. That was a 2011 publication. And then the Nali video was produced in 2014, and that's available on YouTube. And it gives, I think it's a 45-minute video that gives an overview of how tobacco became adopted into culture and how people see that now. So I think they're really great stories from our region. So this is me what TIS program's current aims. So the first one is around denormalizing tobacco, and that's a huge issue for us, is that tobacco is so normalized, particularly with that historical cultural connection to Nali. We are using social media and also Yolngu Radio, which is a local radio station that's in language. And we also had a project with Menzies maybe 2 years ago around successful social media strategies for tackling smoking messaging. And we need to kind of take a strategic approach to how we're rolling that out. So with the most recent transition, we've actually had funding to develop our outreach teams, our public health teams. So we're trying to strengthen our health promotion, our social media strategies across the organisation, and build that capacity, because a lot of things have been happening kind of piecemeal and ad hoc. And we also want to develop curriculums for when we're doing education in schools, so that workers have a clear kind of pathway. So this is what happens the first time they go in, and then they go in and share a different story, rather than just kind of that being quite piecemeal as well. We're working a lot at the moment to try and develop cross-program collaborations. I think TIS have been quite separate to the rest of the organisation, so we're trying to bring them in to other programs and work with the clinics and kind of develop their capacity around the different health programs that we have, whether it's working with the kidney health program, working with the Strong Women program, to increase their understanding of the impacts of tobacco across a range of programs and provide that support for our primary healthcare teams as well. Much of the work in recent years at MeWatch has been around the smoke-free homes and smoke-free spaces, which has its challenges as well. I've got some more information on the smoke-free homes on the next slide, but I don't think there's necessarily been a sustained approach to that as well. Yeah. And sorry, I'll just quickly finish this one. So, and a lot of the focus has been on the youth. So we've been trying to divert young people before they start smoking. So healthy lifestyles, a lot of collaborations with sports programs within our region. So this was some of the data from our smoke-free homes. Around 60% of people surveyed mentioned health of children as a primary driver for wanting to have a smoke-free home. So we know that people are getting the message around passive smoking, and people are identifying that they want their home to be smoke-free, but it's challenging with overcrowding and the number of people that are coming through houses to enforce that. This was serving of your miak, which is women, and stress. Stress was identified as the most common reason that women were smoking. And less than a third of the women surveyed reported that they actually enjoy smoking. So there is motivation to quit there. Let's start providing the support. This is just some photos of our TIS workers doing community-based education. So that can happen in community spaces or on country. Learning on country is really a really key strategy for our program, taking people out of community, away from where cigarettes are available. We know that smoking in homelands, the rates are much lower than they are in the communities. And it's about building those relationships and sharing stories in language. These are kind of what we've identified as the key challenges. So our health workforce have really high turnover. They don't build relationships with the community. Our TIS program don't have workspaces. They're kind of just, they float around and they have a car, but they don't have somewhere to work from, which can be challenging. We haven't had a lot of female TIS workers, so working with the pregnant women has been difficult because culturally the men can't do that. And uptake of quit support training for clinicians is really difficult because it's 2 to 3 days of training and they have to fly out of community to Nhulunbuy to do that, and takes them away from their actual service delivery. Quitline, we know, isn't being used by Yolngu. It's not seen as something that meets their needs. Calling up a phone line, talking to someone in English, it's not going to happen. So we did have Council SA in Nhulunbuy recently, and we're talking to them about alternate models for how that can look and how we can support people to access that service better. Access to services, more generally, accessing support outside of office hours, like community life doesn't happen between 8 and 4:30, and access to social and emotional wellbeing services. And I already talked about the knowledge, attitudes and beliefs around Nali as being a cultural part of culture is also a barrier. So this is my last slide. The next 2 years, the key areas that we want to work on are better data collection, so using a strengths-based approach, understanding success stories of women who have quit during pregnancy, and understanding more about what women know about the harms. We know that the passive smoking message is getting through, but there are stories around, not people wanting small babies, thinking that childbirth is going to be less painful, and so that obviously the chronic disease story isn't coming across. Collaboration with a variety of programs that are working with families and pregnant women, and continuing organisational advocacy to address social determinants, including overcrowding, food security, and things that have been mentioned previously. That went really quickly.